Is coming bioethics, sponsors of this event, Ethics Lunch. And since we're on the eve of Thanksgiving, I wanted to pause and just express gratitude to all the people that help make this happen every month, which is no small task. Peter Young, Alan Regular, Mark, and our amazing Ethics Committee. Many of you may not know our committee members volunteer their time to serve in this capacity, and they are an incredible resource that we draw on very frequently, so I want to just thank them too. And I also want to thank Dan Finkelstein for helping to secure the resources to make this happen. So we have a lot to be thankful for as we're thinking about moving forward with our efforts to integrate ethics more fully into our day-to-day practice. And today is no exception. We have an incredible panel today, and they're going to be focusing on the question of liver transplantation for alcoholic hepatitis. Who should get society's precious resources? And to help guide us in that discussion, I'm going to introduce Dr. Andy Cameron, who is the Chief of Transplant here at Johns Hopkins and the Surgical Director of the Liver Transplant Program, and is very intimately involved in the care of these patients and the selection. So I'm going to turn it over to Andy and let him introduce his panel, and then we will hear from them and open it up for questions from all of you. So be thinking about the questions you want to have the panel address. Andy?
You want me up there or down here?
Wherever you want to be. You can be here.
Yeah.
Just put your mic on.
Can you guys hear me okay?
Yeah, just push it for a second.
Still check screen.
How's that? How's that? Okay. Welcome everyone. Thanks for coming. I am Andrew Cameron. I'm one of the members of this fantastic team. Many of whom are in the audience here. Good to see some friendly faces. We have a panel that is still developing. Jason Wheatley and Lauren Boyer are going to help lead this discussion, and I'll have them describe their role on the team, you know, as the mic moves down to them. We also have Amit Gurukar coming, who is the medical director of the liver transplant team, and Mara Belton is coming as well. And, you know, she's got some sick kids, but if she shows up, we'll have her say hello as well. So, we have an hour or less, so however much time we want, and the discussion can go wherever you like. We have a case which we've selected, which I may read through quickly, and then I will give a minute on my take of how this case and current events in transplantation bring to the fore some interesting ethical issues. But for sure, we are here for everyone to talk and for everyone to give their opinion or their response. So let me start by briefly running you through this case, if that's okay. 52-year-old man with a history of heavy alcohol use was transferred to Hopkins from an outside hospital after presenting an acute alcohol withdrawal. He remained inpatient for over a month with alcoholic hepatitis, altered mental status, and acute kidney injury. He was discharged home, but returned soon thereafter with weakness, nausea, jaundice, and severe hepatic encephalopathy. He had a calculated MELD score, we can talk about that, if need be, of 38. That means he is certain to die with mathematical certainty in the very near future from his liver failure. He underwent liver transplant from a deceased donor 2 months after his transfer. He tolerated the procedure well, recovered from a postoperative bleed and infection, and was discharged home on postoperative day 17 to pursue sobriety via outpatient rehab. That's the story. The patient was born in the Baltimore, Washington region. He'd been married for 30 years. He had a 20-year-old daughter, both of whom strongly supported him in his transplant candidacy. He worked as a support staff in an assisted living facility for 15 years. The drinking history, he began drinking at the age of 16, 2 to 3 beers per episode, 2 to 3 times per week. continued until his late 20s when he began drinking vodka. Drinking increased in frequency and intensity during that time, 1 pint of vodka per day. Slowed down after some legal trouble, beer only, 6 beers a day. Continued this pattern up and down, ultimately returning to 1 pint of liquor a day. He had a second encounter with the law, 6 beers, on and on it goes. Ultimately presented the emergency room in acute withdrawal, transferred to Hopkins. That's the story of this patient. It's quite a story. So, we can talk about it and what we can do for patients like this. I think the discussion has, in my opinion, 2 important background points that we all need to know. Okay, so point number 1 to understand what happened here is the following reality, okay? Over the last 40 to 50 years, organ transplantation in general, liver transplantation in particular, has gone from science fiction experiment to wildly successful clinical reality. Okay? So patients that can no longer breathe, patients that their heart is about to stop beating, patients committed to dialysis, patients in horribly ill liver failure are now given organ transplants and are then converted back to indistinguishable, happy, healthy, normal members of society with almost normal lifespans. It's remarkable, and it's wonderful to be a part of a team that helps effectuate that. That is the good news. The bad news is that transplant is then a victim of its own success, in that there are far many more people that need organs than we have organs for them. So as a result, sort of, problem or reality number 1 is that we require a system to allocate or prioritize the many needy people on the list, okay? So in general, 100,000 people on the wait list in the United States, 18 people die every day in the United States for lack of an organ. We'll have this talk, lunch. Somebody will die during that 1 hour because they could not get a transplant. Easily savable, salvageable people, not enough organs to go around. We have to allocate that resource. We're going to talk about that. I don't make that decision. This team doesn't make that decision. The decision on how to allocate those organs has already been made at a national level by a government agency called UNOS, who has decided, again to preface this discussion, that sickest first. That's going to be the rule for liver. We talked about a MELD score. That person was certain to die in the very near future without a liver transplant. That's why he was allocated an organ, by the national decision-making process. That's point number 1. Point number 2, and then I'm going to turn over the mic, is that this patient showed up at Johns Hopkins, critically ill, with alcoholic hepatitis and really no other treatment option. Again, almost mathematically certain to die within a week or 2. In general, in liver transplantation, the most common indication is hepatitis C infection. The second most common indication is alcohol use. There is a national unwritten rule that in order to get your transplant for alcohol use, you have to be sober for 6 months. You have to abstain, and that, I think that's, for most people, is common sense. It's a statement of good faith. The notion is you've got that behind you. Post-transplant, you're going to do a good job. You're not going to. Patients like this, they don't have 6 months. This patient will die trying to turn in 6 months of sobriety. So what do we do with patients like this? They are allowed to die. In 2012, there was a shocker. A paper in the New England Journal of Medicine published a liver transplant series from the entire country of France, in which 7 transplant centers decided to not let these people like this patient die, but rather to go ahead and suspend the 6-month rule and transplant them. Lo and behold, the 26 patients that they transplanted, 80% of them were alive and well 6 months or a year later, as opposed to 80% of them dying. And again, even more interestingly, very, very few of them went back to drinking. In fact, the same percentage as folks that had had 6 months sobriety prior to their liver transplant. That was a controversial shock. So I'm going to stop there and say that patients like this come to Johns Hopkins. They're transferred in. We are presented with critically ill patients that will for sure die. We now know that we have a life-saving therapy for them in liver transplant, which we would have to withhold from them and let them die. That's what we can discuss. Or go ahead and transplant them and see how it goes. And if you're interested in that, we can tell. We've been doing some patients like this, as you can see, and we can tell you how it went. So that, again, let's have at it. And for me, that's where we're at. Transplantation is thriving and booming. We have tough decisions to make. Patients like this maybe make those decisions even tougher. These decisions are made by communities, national communities. So everybody in here, you get an opinion, you get a say, and we can give you our perspective from the sort of ground level of taking care of these folks. With that, I will have the other members of the panel maybe say hello, introduce yourself, and start the discussion.
My name is Maura Belden. I'm the Assistant Director of Transplant Nursing, and I play an active role in the management of the liver transplant patients post-operatively.
I'm Jason Wheatley. I'm one of the social workers, of which there are several of them here today, who work with our patients both in evaluation and post-operative care. We help evaluate our patients for psychosocial barriers to transplant.
I'm Lauren Boyer. I'm the lead nurse practitioner for the outpatient liver transplant, so I typically follow them mostly outpatient, and so from the time of transplant down to a year.
Amit Gurkar from Transplant Pathology. So from the medical perspective, obviously our job is to safely transfer those patients from an outside facility into Johns Hopkins, having some preliminary psychiatric and social assessment done at the other hospital. And also we also oversee the workup period and get everybody on board to decide whether this specific patient is transplantable or not. So I think our job basically for patient selection and what we would, and then post-transplant planning if we can.
So, anybody have any comments off the top of their head about maybe allocating organs, how we do it? Fair, unfair, wise, unwise, or about this patient in general, or about, reasons to need a liver transplant and whether that should affect who gets one.
So I just had a question about, you have a situation where 2 or 3 people have the exact same MEL score, or if they're in a situation where the likelihood of death is equal for these 3 or more people. Is there a lottery or something then that gets applied at that level?
So there are 20,000 people on the liver transplant wait list right now, and they presumably all have MELs that the score goes from 6 to 40, but you're right, there will be a lot of ties in there. There will be, for any liver out there, 10 people with a 40. The technical answer to your question is the liver gets allocated to the person who has been at that 40 the longest. So again, the notion being they can't wait, they're hanging on for dear life, they go next. And I guess this gets at the crucial question of sort of who gets this limited resource. The sickest person, the person that will die without. Now note, that's it. That's the discussion. It's not necessarily who will do well with it. It's who will do poorly without it. Not the same thing. nor is there any particular notion of societal value or what you will do after. You know, none of the above. It's a bit utilitarian.
Could you talk about the process of being listed in multiple transplant centers, and I guess sometimes folks with a little more influence or money can be listed in multiple places, and whether that and how that influences their ability to get a liver?
That is a great question, and I'll let Ahmed address that or Mara or whoever. I will say everybody knows Steve Jobs got a liver transplant. Steve Jobs got a liver transplant in Memphis, Tennessee. So makes you scratch your head how that happened. And there's a story behind it. I think you're getting into this is getting into fairness. Is it fair when Steve Jobs got a liver transplant? One of my patients from East Baltimore needed a liver. Would they be able to fly to Memphis, Tennessee and get that liver? Do you want to address that?
Yeah, I think very good question. I think I agree with Dr. Cameron, but one thing I want to ask if he doesn't mind. Are you asking that question specific for alcoholic hepatitis patients or in general? Because I think our concern over here, I think we're mostly discussing alcoholic hepatitis. If your question is alcoholic hepatitis, I think the question is not going to be relevant because there are not too many centers around the country doing this type of liver transplantation. So to answer your questions, yes, since I answer most of the phone calls, I've been getting phone calls from Florida, from North Carolina, as well as like the surrounding states, Delaware, Virginia, Pennsylvania. But if the patients come from out of town, out of state, so to speak, unfortunately, the first question I ask, maybe that's pertinent to your question, do they have state-sponsored medical insurance, like state Medicaid, or private insurance? So I had a similar issue with North Carolina. It took them like 12 hours to figure out what kind of insurance the patient has. And then it was a Sunday afternoon, and they told me it's got North Carolina insurance. I said, it's difficult to bring a patient with state-sponsored insurance from North Carolina because there are like 4 or 5 very reputable transplant programs in the state. And then if you bring on a Sunday with no North Carolina Medicaid being informed, and then on Monday we call and ask for the state sponsoring this transplant, I can guarantee 100% they're going to say no. Because there's a new indication for transplantation, and that state requires 6 months sobriety. So I hope that I answered your question. So it's not like the money and the other stuff, but what are the circumstances on that specific moment for alcoholic hepatitis patients?
Here's the thing that you're getting at the notion that there is heterogeneity across the country. So in general, we can talk about it, but I don't think anybody in this audience would say that if you need a hernia or a cabbage, your ability to get that should depend on whether you're from Appalachia or Los Angeles or Topeka, Kansas. That, I think we all agree there are disparities in access to health care which are probably undesirable. Now, liver transplant is the poster child for heterogeneity to access. The country is gerrymandered into these bizarre 11 or 12 districts which compete internally, Hunger Games style, for the livers. And the average MELD score that you have to get a transplant in Los Angeles is very different from Jacksonville, Florida, or Memphis, Tennessee. That is bad. That is undesirable. The government, in an effort to correct that, wants to have everybody get transplanted at the same level and have everybody have equal access. So, in order to fix that problem, they have said to us, when you need a patient, you are obliged by federal law to tell them you can and should dual list, because not every transplant center transplants at the same MELD. So in the name of fairness, patients are told they should list at more than one transplant center. If you are Steve Jobs and you live in San Francisco or Palo Alto, that's a bad place to try and get a liver transplant. If you have tons of means, you can, in fairness, learn the system, get on your private plane, and fly to the place where they have lower amounts, Memphis, Tennessee. That's fair and square. He didn't buy a liver. It was appropriate. In fact, it was our federal law to inform him of his right to do that. If you are a person of average or lesser means, that may not be realistic. So in the name of fairness, we do have a system in which some people can get livers easier than other people can, and that is undesirable for sure. And so, limited resources begin to introduce many ethical issues, including disparities of access. And that's a problem. It's what we want to fix.
And to further couch that point, here in Baltimore is definitely not a place where you're going to get transplanted with a MELD of 20 and you're relatively hale. This is a place where most people are very severely ill before they're ill enough to get a transplant. So, in the context of what we're speaking about today, alcoholic hepatitis, we'd love to hear your thoughts or questions about what that means in a place where it is difficult to get a transplant. Lots of questions.
Yes.
My pockets are stuck to the, at least they didn't dump like in medical school. My name is Danielle Dobrin. I'm the new medical director for palliative medicine. I've been at Hopkins now 4.5 months. I came from George Washington, which is a level 1 trauma, so patients were also brought in from surrounding hospitals. And we had a very difficult case on our team of a gentleman who had alcoholic hepatitis. And we got consulted because he had end-stage liver disease and was starting to bleed from multiple places. And they wanted us to discuss hospice with the family, and he was in his mid-30s. And as we were being asked to discuss hospice, he had a sister who was trying to find if he could qualify for a transplant. And it was very challenging because he had encephalopathy and wasn't always able to participate, and his parents were trying to move towards acceptance of allowing him to die. And his sister was trying to find anything possible for him to live. He owned a bar, so we were concerned about recidivism. And he tried multiple times to stop drinking and had never been successful in the past. And right as he was about to be discharged to an inpatient hospice, she was able to find, I think actually the University of Maryland was going to accept him, at least for evaluation for transplant. She interpreted, we will accept you for evaluation, as he will get a liver. And that was also very challenging for us as a palliative team because we were working towards the family emotionally allowing him possibly to die. And now they had new messages. One that was clearly more hopeful and one we wanted to support, but we wanted them to understand the subtlety of what was being said. That it wasn't a definitive liver, it was just an evaluation. And that even if he got a liver, the amount of supports for somebody who had severed relationships with most of the people in the family because of his aberrant behavior. He owned a bar. What are you going to do when his entire income and health insurance are from the bar? And it was a big challenge for us as a team because here we'd set up all these services for him to go to hospice, and then now many of the house staff were angry at us because our care plan was falling apart. And were we going to get him, who was going to get the ambulance now? And there's practicalities that triggered anger, but it wasn't anger on who was going to get the ambulance. It really was everybody's frustration with this case and the family weeping in the hall and who was going to help them. So I think that's a subtlety that maybe families need education on. And the after effects also, he was a single man, so who's going to keep him sober? Who's going to help him? I know from other transplants I'm working with Georgetown, that one of the screening criteria is who is your support system? Who's going to help you to take all your anti-rejection drugs? And the sister was like, I'm going to move to DC and help him. But that sounds real good in a crisis, but what do you do month 2, 3, and 4 when his bad boy behavior comes back out? So if you could just speak to the longer term consequences.
Thank you very much. If you don't mind, Jason, I can start with the first physician evaluating on the phone and trying to bring the patient over here as a transfer. The way that we do it here, I think we have one designated physician, which is me most of the time. He gets the first phone call, and I always have that kind of discussion with the referring physician. And what happens that my motto is that start educating the referring physician first. Make sure they understand this is not a revolving door. One of the things that I ask the physician, do you see a family next to the bedside? And I get like 80% the answer said, why you are asking that? That is not relevant here. I mean, my patient is dying and you're asking who's at the bedside. And then immediately gives me an idea saying that I have to do a little bit more education. I try to say that this is a social issue. I need to know what the support system is. And well, the question is that how am I going to bring it to the family's attention? I said, look, get a social worker and go and talk to the patient's family with the social worker. Tell them, here's my name, that I'm asking from the transplant center. Who is going to be responsible of taking him to 6-month alcohol rehabilitation after the transplant? Specifically, we tell them we are not eliminating the fact that they need 6 months of rehab. We are delaying the rehab until after the transplant. That's what the protocol is. Most people think that the protocol is that you drink until yesterday and then you get liver failure today and you get a liver transplant tomorrow. So I think there's a lot of education starting at the level of the referring physician saying that please tell the family this is not like where, I mean, if you look at the Medicare guidelines, all the patients need 6 months rehabilitation. But it doesn't say pre-transplant or post-transplant. Basically, we are just delaying the requirement until after the transplant. So I think we should leave the responsibility on the referring centers, social workers, psychologists, or psychiatrists. If they write in the chart saying that this patient has no means of doing 6 months rehabilitation post-transplantation, I think I rest my case. I don't think we'll do everything out of ordinary to bring the case here. So I think every center has to take a responsibility. Referring centers usually saying, okay, I refer the patient to you, it's all your responsibility. Yes, I think it's my responsibility to bring the patient here safely to Johns Hopkins, but there's also responsibility on the referring side. I think it's not undoable to get I understand if it's over a weekend, but during the working day, bring a social worker. They may not be very experienced in liver transplantation, I understand, but the basics, what the patient was doing, for example, I think you've got a great social history. The patient works in a bar, and limited resources, blah, blah, and then you made a comment that the sister, at the time of the crisis, bless her heart, she did the right thing. I'll do everything for my brother. That's what we want to hear. But that sister should be put aside and thought about, look, are you committing yourself for 6 months minimum? It's not like you do everything. If she says yes, I will proceed from that. And then look at her resources. It's not like I say yes, but how about her resources? We have to document that.
So Jason Wheatley does a lot of the evaluations along with other members of
Once
the
she
team.
gets there, then
Yeah,
it's the real professionals.
Exactly. So it might be helpful to give your perspective. So owns a bar. I mean, that sounds like so bad that how could it possibly work out? Could you give some type of objective viewpoint on what predicts success or lack thereof after transplant for somebody that's in this type of situation?
So, you know, as Dr. Gerber described, we certainly go through a screening process, and at times rather rigorous, particularly if you hear certain things like individual ones are. That doesn't mean that they would necessarily preclude him from getting here for evaluation. When he gets here, either myself or my colleague Nicole would sit down with that individual and their family. Oftentimes, as was already mentioned, the patients themselves may not always be lucid and be able to, give a lot of information. So we're sometimes relying on corroborating information from the family. We will then go through the process of this is an evaluation. You're not sure whether it's going to happen. We're going to make a decision as a committee. So yes, how we allocate organs has been decided from the national level. Whom we decide to put on that transplant list is decided as a committee. So they have to be surgically viable, medically viable, and then they have to meet certain psychosocial criteria, of which we need to find out, is there a designated caregiver, and what is the realistic plan that that caregiver can be present, typically for, 24/7 for about 30 days post-transplant. We look at the individual's history, their attempts at sobriety, whether or not they've known about their illness, typically speaking, and in fact that New England Journal paper, everyone that participated in that study was very carefully selected for individuals that did not know about their illness, had stellar psychosocial support, and were willing to commit to 6 months of relapse prevention counseling post-op. We're looking for similar things as well. In the case of the case study that we gave in the paper today, as well as with this gentleman, we're going to look at whether or not he knew about his illness, his history of drinking, and whether or not he's shown any semblance of trying to learn from his behavior. This gentleman, for instance, had 2 different legal problems, 2 different DUIs, 20 years apart, where he attempted some sobriety and didn't stay completely sober. He cut back, let's say. But he's somebody that we struggled quite a bit with our decision to list. One of my favorite things to say to the team and committee is that this person has had ample opportunity to realize that alcohol was ruining their life, and he certainly did. We deferred him initially, so this is somebody that we did not rush to get on the list. But in light of the fact that some people like this individual and others will come to us not able to survive our sort of standard 6 months of sobriety golden rule, so to speak, which is somewhat arbitrary. It's not really based on a lot of survival outcome. Then what other factors do we have? Research has shown us that in addition to the New England Journal article, there's other research in there. I think it's been cited in our references. That roughly 27% of people will return to some kind of drinking post-operatively, regardless of the etiology of their disease. So across the board, alcoholic liver disease, autoimmune hepatitis, Hep C, what have you, they're going to go back to drinking something. Of those individuals, overall, 2.5% will return to some kind of injurious amount of alcohol consumption. So a very small percentage. Of that, the 5-year survival rate, even of the people that return to drinking, is identical to those that don't drink. It's about 77 to 80%. So there's certainly a societal value on whether or not this person did this to themselves. And arguably, we could say that people with other disease etiologies did harmful things as well. But that's not our place. Our place is to say, do they medically need a transplant to survive? And do they have the factors that would help support their survival? That being caregiver support. Someone who can be there for at least 30 days post-transplant, and effectively some type of social network that is safe and sober. So obviously not the servers at his bar. Okay. Do they have any premorbid psychiatric condition? That would be more of a contraindication. Not always a deal breaker if they had that. Hasn't been well controlled with therapy and medication. Young age is a contraindication. So while it's not a deal breaker, it is something that we will consider. Because in our own experience as a program, as well as throughout the research, being a younger male puts you at high risk for relapse. Just too culturally exposed to it, perhaps. There's a lot of different And then any individual that's been drinking for longer than 20 years without 2 years or more of collective sobriety prior to transplant. We have definitely transplanted individuals like that. And to be honest, the carrot's off the stick. They already have the transplant. We can't repossess those as much as we'd like to. So they will or will not go to treatment. Some don't, or at least not formal relapse prevention counseling. Some will go to AA or Smart Recovery. Some will dabble and not go back. But even of those individuals that are transplanted for alcoholic liver disease, roughly 27% will return to drinking, and roughly 5% will return to harm.
So there's some hands up. If people have comments, you know, from what you're hearing from Jason or from any of us, be interested to hear your
There's a hand in the back there.
Yep, sure. Go for it. Go for it.
No, I don't have that.
We got time. Everybody got time.
So this was really helpful, Jason?
Yes.
Right? Yeah, Jason's comment was really helpful for me in thinking through some of the reaction that I've been having. So in moral philosophy, sometimes we separate between forward-looking and backward-looking considerations when we do different sorts of evaluations. And one thing that I was thinking through all the conversation is that it would be really hard, first personally, if I was in the room, like it would be really hard for me to keep straight my forward-looking versus backward-looking reactions. You know, so it sounds like the instructions are forward-looking. Will this person do well and survive? And, you know, are they the sickest? And then when they get it, will they now be sick? And that has to do with whether or not they go back to drinking in part. But I imagine, right, all the comments have this like little twinge and it's just human, right? That it's really, really hard to pull apart this kind of desert thesis that humans walk around with. That if you deserve bad things to happen to you, then you ought not get good things, right? And so this language of like, did they do this to themselves? Or, you know, what was some of the other things that were brought up? The comment you make to staff in the room, right? That they've had lots of opportunity to learn. There's a forward-looking version there, right? Like, if they had learned, that would give us evidence that they learned. But there's also a backward-looking inclination there, like, they really screwed this up, right? This is kind of on them. So this is an exploration or a wondering or an invitation to reflect, but if I were in the room, I would have a really, really hard time, and I'd worry about that, right? Because the instructions seem clear, and humans aren't good at that sort of clarity. So I guess I just wondered if I could invite you to reflect a little bit on whether you think that's a real problem, if there are methods for kind of stripping out these sorts of biases or reactions that we might have, or if you think they ought to be, you know, really anything.
Well, first of all, thank you for your candor. You know, and I agree. I do struggle with that as well, as do my colleagues, and I think everyone here at this panel and in the committee. In terms of looking at past behavior, it is often prologue. You know, so it is difficult to separate the individual from their history. I will say to almost everyone that I sit in front of that is lucid enough to talk to, how you get here is how you get here. What you do forward is what we're very concerned about. And that is true. However, I would be lying to you if I said that there were not individuals whose history have damned them in some way. You know, I can tell you I've come across a case that was near identical in terms of disease progression. Both individuals that had an inkling that their liver was having trouble due to their drinking. They may not have heard the C word. Nobody told them they had cirrhosis. But certainly that they had, you know, had liver injury at some point. They've been told they had a fatty liver, whatever, however nebulous that may be to the average person. There's one individual who was able to sit up and look you in the eye and say, I know I did this to myself. I'm sorry and I'm wrong. I will do everything I can to do this better. And who doesn't, you know, start praying when faced with, you know, certain death, right? But had the social support, had all the other factors of it. I had another individual who was not lucid enough to do that, and whose caregiver, while at bedside and very much dedicated, limited to some degree by, you know, financial needs and everything else, was far too candid with me. and painted a picture of someone who knew full well the injury they were having and continued to drink despite it. That individual, ultimately, we had to confront. There are numbers of those individuals, not any one particular case, but what we're really looking for is some sort of insight from the individual, or at least the history of insight. If they've tried and failed, that is part of the disease process of alcoholism. Relapse is part of recovery. It's a trope. But have they at least attempted? Is there the will? Is there at least some sort of insight to say, I know that if I continue in this vein, that this is going to mean certain death, and I'm willing to do something to correct that? You answer.
Question in the back?
I just have a comment. With the exception of the Medicare guidelines, it sounds to me like everything else is subjective to whatever it is that the team says or whoever else says, and it doesn't sound like it's very fair, because you're asking a social worker to get a capable adult to not to do A, B, C, and D. Good luck with that. Most competent adults do whatever they want to do, and then to try to have the family hog-tie him or her to the room without a drink. Good luck with that, because it doesn't always happen, and we can be at the bedside and say, yes, we're going to do this for dad, we're going to do this for mom, and as soon as mom gets out of here, she's at Barclay and 25th Street at the bar. You know, it's but so much the healthcare professionals can do, but then to hear the presentations like, well, if you don't do this, and we're going to not do that, you know, I mean, it just doesn't sound very user-friendly, for lack of a better. True, we all do things ourselves every day to harm ourselves, but are we held, you know, captive to that, or are we denied access to care or screenings?
So I really like your points. These are all really good points. You're absolutely right. The only thing objective is this national system that says who can get a liver. So meaning if you're placed on a transplant list, you will be at the top of the list. That's objective. The subjective part, which I think we're all struggling with, and we are still learning for sure, is who to put on the list and who not to put on the list. And it's almost the same thing, because if we don't put you on the list, then you don't get a liver. If you do, then sure enough, you're at the top of the list. It sounds subjective in sort of, well, let's take a chance on this person, but not on this person. We don't like that either. We are trying to make it more objective in terms of what are the factors that we know will predict success after transplant versus the objective factors that will predict failure after transplant. It actually can get pretty objective in terms of family support or previous interactions with doctors about your illness. And we've gone so far as to make sort of a scoring system of people that we know will be in trouble. What I think is interesting with this discussion is that everybody's pretty good at figuring out, let's try and figure out who should or shouldn't get one. And I just want to say, think about it, that's really very different from every other aspect of medicine at Johns Hopkins. If somebody comes in with lung cancer, there isn't really a discussion, hey, you smoked, you did this to yourself, no lung resection for you. If somebody jumps off a bridge, we pull the person out and do CPR. We don't say, you did this to yourself, why would I help you? This discussion in transplantation is very, very different from other discussions that care providers would typically have when faced with ill patients that they know they can save. I mean, again, back to the data, though these patients sound like train wrecks, we save 98% of them. This is the sort of problem, my second problem. We've transplanted 50 patients like the one presented, 98% of them, 49 of them, are alive and well. So we're sort of burdened with the fact that we know we can save them. We would have to actively deprive them of the therapy. And sometimes we do. But if we're going to, you better have your story straight as to why you're depriving the person when the family says, what do you mean? We came here for help, doc, and you're telling me you could save them, but you're not going to. Obviously, the sticking point is, it's a limited resource and it can go to somebody else. So that's where we have to make these tough decisions. What I was going to bring up was the case that was presented about the sister that would be willing to do everything for the brother. What if that sister said, I will give him half of my liver? Now, that works too. We do plenty of those at Johns Hopkins, living donor liver transplant. And that takes the discussion away from, I get to decide because it's a limited resource and I am the person who's going to decide how to best allocate it, into there's a therapy, you could avail yourself of it, we could do it tomorrow morning, nobody else is going to get her liver, it's going to go to waste, do it or don't do it. Then you really have to address your concerns about, I just don't think you deserve it. And that takes us into uncomfortable waters, but I'm happy to hear anybody else's ideas.
So, I'm going to ask a question. I actually, when I heard the study results that whether you ask for 6 months of sobriety first or not, the relapse rate is the same. For me, it kind of just felt over. Maybe I'm just overly pushed by numbers, but I thought, okay, then no need for the 6 month sobriety test. That sounds fine. But the fact that we're having this discussion means that that's not fine for some people. And I'm wondering two things. First, have you sensed within your team if it is harder or there's less enthusiasm or team morale is lower when you are transplanting an active alcoholic? And how does that affect the team dynamic when caring for that patient? And two, do you think that changing attitudes towards addiction as a result of the opioid epidemic as it moves into more middle class and white communities and feelings about addiction change are carrying over to your patients? Or is alcoholism still treated as a completely different form of addiction?
Wow, you're a pro. You're a pro.
Wonderful.
So wait, what was the first part?
So, I think one question, I think, the first part was, I think you said actively drinking person being transplanted. I'm not sure if we are actively drinking. You mean active drinking means that they were drinking yesterday and now they're getting a liver transplant.
6 months sobriety. That's all right.
So I think that's what we need, that's what we're preaching. I mean, 6 months sobriety, if you're 5.5 months sober, you're called active drinking. So I think that's what we need to train ourselves. I think instead of using the term active drinking, I would just say how sick the patients at that point and how much sobriety they have. So I think if we talk to the society, well, at Johns Hopkins, they're active drinking patients being transplanted. So my question is that what happens if a person is 5.5 months sober? So I think we could just say maybe patients do not have like 6 months of sobriety. I think that's going to be a better way of putting it into society. That was my, I think, comment for the first part, I think.
In terms of the 6 months too, a lot of insurance companies mandate that. So when we're sending approval for listing to our insurance companies, they'll say we need documentation. And it basically, we then as healthcare providers have to go back to the patient and assess whether they're well enough to complete those 6 months. A lot of the patients that we're kind of discussing, and particularly the individual discussing today, don't have 6 months to live. And so if you come across a patient with adequate support and with the knowledge that they need to go into rehabilitation and their MELD score is low enough where they can participate in 6 months sobriety and get engaged in rehab, then we obviously encourage it. But if there are these patients like the patient we presented today that are acute hepatitis and come in pulmonary with liver failure and they don't have the 6 months to prove to us that they're sobriety, then we have the research that we've presented today as well, the kind of criteria that we then have a committee decision to say, let's either commit to this patient or not. And post-transplant, we allocate a ton of resources to these patients. So, when we meet as a committee weekly too, it's not one person that makes the decision. We have nursing advocates, we have social work support, we have a surgeon present, we have a hepatologist present, finance, and nutrition, and pharmacy. So it's a multidisciplinary approach. And if we risk stratify these patients as high risk post-transplant, then obviously we're going to allocate a ton of resources to them on the post-transplant end and make sure that they get a good psychosocial evaluation post-transplant as well, and make sure that we engage the family as much as possible to try to make sure that they're successful.
Can I say 2 quick things? The 6-month thing, I totally agree. So it's neither sensitive nor specific. So it's kind of funny because people hear that we're doing this and they often react negatively as if we are being bad shepherds of this limited resource. We're being too casual, we're being too cavalier with the resource. We're trying to do a better job. 6 months is a very brain-dead, non-helpful rule. That's a lazy rule. Like Ahmed says, 5.5 months, no go, 6.5 months, you're perfect. We know that doesn't predict post-transplant sobriety. So where's that come from? That's the lazy way to do it. The more proactive, careful shepherd of the resources says, I have looked carefully. It's whether you have family support, it's whether you have had sobriety in the past, it's whether you have untreated mental illness. There are rigorous, careful ways to do this. When you do it that way, the time element falls out. So though it's inflammatory, we think we're being more careful shepherds of the resource, even though people don't like this idea of dispensing with the 6 months. Your other point was awesome too. Is the team unanimous? No. There's, just as in this room, there are different opinions on our highly dedicated, hardworking team. Amongst those people who do anything for these patients, there are differences of opinion, as I would expect and I would want and encourage. When we have a patient that dies after transplant, it is crushing to the team, to the family. You know, the donor gift goes sort of unfulfilled. When somebody that we take a chance on, bending the rules, if you will, goes back to drinking, it's that and worse. And the differences of opinion on the team are then brought back out and amplified. And it's very problematic. And it's heavy lifting. And it's morale and soul crushing on our team. Maybe enough to make you think we shouldn't do it at all. I'll go one step further. The whole system of donation in the United States depends on the folks, the families, the loved ones of those that die say, my loved one's gone, you can have this gift, go save a life of someone we will never know. There's nothing in it for me, it won't help us any, go do something good. If there was the sense that we were taking that gift and using it unwisely in people that the public wouldn't support or agree with, that will be very problematic and people will stop donating. I know what you do with those livers. They go to rich people. They go to drunk people. I'm not going for that. The whole system is based on generosity. If we are not perceived as good shepherds of that limited resource, we're doing the public a disservice and we're going to be out of business. So it's our team I worry about, it's the whole country I worry about, but I also got to worry about these people that show up whose lives are savable. That's the tension on our team. And it's tense.
I agree with Dr. Cameron, but one other thing that I want to mention over here is that liver transplant is a surgical therapy for alcohol liver disease or alcohol hepatitis. Obviously, we try medical therapy before we offer surgical therapy. So all the patients are given a chance if they will respond to prednisolone or prednisone therapy first. So we get phone calls from an emergency room, patients alcoholic hepatitis, but actively withdrawing. We don't bring those patients to transplant service. We bring them to good OZOS medicine service. The medical rehab staff takes care of the patient. If needed, if there's no absolute contraindication for prednisolone, they take care of the prednisolone. They try to treat the patient with prednisolone. In case the patient does not respond, then what to do? Then the surgical therapy comes in. That's why we get involved. The same thing, when we get a referral from an inpatient outside, they usually call us saying that, Doc, we are referring the patient to you because this patient was on prednisone for 2.5 weeks and she's just getting worse. And we don't have anything else to offer. So that's a legitimate transfer. I think we helped those patients at that time. But it's not like we straight take from withdrawing out seizures into transplant. I think this is not happening. That's one of the things I think we need to clarify. At least there's like 4, 6, 8 weeks of time before even the patients referred to transplant center.
So I have a question, picking back up on what Travis said and some other comments about the subjectivity that is possible in these kinds of deliberations. And I'm wondering if you've thought about some procedural safeguards that could be put into the process and how you might involve, obviously you are all a dedicated group and committed to transplant. And there's a certain bias that goes along with that. How might you have other voices that may bring other perspectives into your deliberations? So community representation, people who are non-transplant providers, to participate in that evaluation, to add some other perspectives into it rather than, you know, your very dedicated team who has a lot of experience. Have you thought about that?
I'd be interested in Jason's take on that. We don't have what you described. We have an open meeting once a week, probably attended by 30 people, multidisciplinary in its nature, and we present the patients, and then we have essentially a vote. And I will say there's basically veto power invested in everybody in the room. And if cardiology says this patient will not get to a liver transplant, we don't do the case. No matter how much we want to do it or we're emotionally invested. If surgically I say it's undoable, no. If Jason or Nicole or Angie says this is not going to be a successful transplant, broadly defined, we don't do the case. So that doesn't incorporate some of the elements you're suggesting. It is an attempt to move it away from one person's emotional preference to group strategy. Focusing, again, sort of forward thinking, what will work? Almost sort of moving away from who does or doesn't deserve it to what will be successful. And once, we don't want to do things that are futile. From a cardiology perspective, from a surgical perspective, or from a social perspective. We don't want to have people fail for transplants in any of those regards. But it's not, the outside perspectives, you know, they're not in that room. It's a mixed group of people in a very good way, but not to the extent that you're describing. Jason, go ahead.
Right, and I would agree with that. I think the multidisciplinary approach is the strength of the selection committee in that regard, because we are, we are coming from a medical and surgical perspective, and in this case, multiple medicine services, cardiology, even at times, because the liver is so intrinsically involved with the kidneys, nephrology, and so a number of medical disciplines. And we've explored, as Dr. Gurkar mentioned, as many medicinal options, non-surgical options as possible. So sort of transplant is the intervention of last resort to a degree. In terms of finding an equitable way of getting some of the subjectivity out of it, there are metrics that have been used over the years that have been validated time and again that we're familiarizing ourselves with more and trying to incorporate into our work, which is essentially risk stratification. So we're attempting always to find better ways of risk stratifying patients, rather not as a way of exclusion, but as a way of seeing what interventions are necessary. And to briefly touch back on a previous point about allocation of resources and team morale, there is no doubt that the higher risk patients, albeit ones that have drank up until, their need for transplant, or ones that engage in other high-risk behaviors, intermittent adherence, have limited resources, limited caregiver support. There's a number of reasons why transplant can fail, and certainly substance use is only a fraction of that, aren't they? Those individuals do take a large number of our resources. Say, to make up a figure off the top of my head, it could easily be said that 5 to 10% of the people that we transplant are using a huge portion of our resources. So how we can risk stratify those individuals in a better way, so that we can allocate those resources responsibly, because we are looking at the fact that we as a transplant center have to provide these interventions, medically, psychosocially, and we can only be stretched so thin.
Of the 50 that you say in this scenario that you've done, how many have you turned down?
Oh, good question.
Um,
It's published, and I should have that data at my fingertips, a much larger fraction. So for the pipeline is that there are a whole bunch of people out there sick and outside hospitals. Amit accepts a small number of them that are not grossly inappropriate to be considered for further care and possible transplantation. The folks that get transferred in here represent another denominator, some of whom die waiting, some of whom have bad hearts, some of whom are infected. It is a small percentage that get listed. Some die on the transplant wait list. A very, very small percent get better, or at least get better enough to go home and not need an emergency transplant, maybe come back 6 months later, for example. So the percentage of that 50 is probably, 5 or 10% of all the patients that get considered for being ill and giving us a call. And that is relevant, I think. It's a relatively small number of people, highly selected at this point in time, that I think for that reason do give the very, very high survival, 98% on the back end. It's ironically better than any other indication for liver transplant, including alcoholic cirrhosis with 6 months sobriety, who tend to have, 90% on their survival.
How do you compare your institution with other centers that might have a higher MELD or a lower MELD or whatever?
So we're the only game in town. We are the only center in the United States that's published on this, sort of admitted to it. Nobody else really does it. As a result, we get referrals from up and down the East Coast. Pittsburgh, a very aggressive transplant center. UVA, we're going to let this person die. Do you want us to transfer him or not? So we now, again, victim of our own success, get more and more and more of these type of referrals. We're trying to figure out our comfort level with helping them, but again, we, at this point, are having very good success. In terms of how they compare to other patients, they are the sickest of the sick. They have the highest scores. They are for sure going to die in the immediate near future without a transplant. And again, that's what we got to balance. Should we quit there?
Okay.
All right. Everybody, thanks for coming.